Hello. Today I will be sharing with you Rachel P. Main's book, The Technology of Orgasm, Hysteria, the Vibrator, and Women's Sexual Satisfaction. For the purpose of this presentation, I will be focusing on Chapter 1, which is called The Job Nobody Wanted. Main's research begins with a 1653 medical compendium that included a chapter on the diseases of women, specifically the affliction commonly called hysteria. In Western medical tradition, genital massage to orgasm by a physician or a midwife was the standard treatment for hysteria. Mainz provides a brief yet surprisingly extensive literature review and that provides a breadth of descriptions of this treatment in medical literature. But during her research, she realized that there was a complete absence of a conversation of the character and purpose of these massage treatments for hysteria and related disorders in scholarly conversation amongst historians and humanists. Maine says, this purported disease and its sister ailments displayed a symptomology consistent with the normal functioning of female sexuality, for which relief, not surprisingly, was obtained through orgasm, either through intercourse in the marriage bed or by means of massage on a physician's table. I shall place this disease paradigm in the context of the androcentric definitions of sexuality, which explain both why such treatments were socially and ethically permissible for doctors and why women required them. Androcentric views of sexuality and their implications for women and for the physicians who treated them shaped the development not only of the concept of female sexual pathologies, but also of the instruments designed to cope with them. Rachel Mainz uses the vibrator and its predecessors in the history of medical massage technologies to explore three major themes. 1. Androcentric definitions of sexuality and the construction of ideal female sexuality to fit them. 2. Reduction of female sexual behavior outside the androcentric standard to disease paradigms requiring treatment. And 3. The means by which physicians legitimated and justified the clinical production of orgasm in women as treatment for these diseases. When the vibrator emerged as an electromechanical medical instrument at the end of the 19th century, it evolved from a more hands-on approach in response to demand from physicians, who were all male at the time, for more rapid and efficient physical therapies for hysteria. Mechanizing this task enabled an increase of patients to be treated in a day. It's all about the dollar sign, right? Mainz writes, doctors were a male elite with control of their working lives and instrumentation, and efficiency gains in the medical production of orgasm for payment could increase income. Physicians had both the means and the motivation to mechanize. Okay, so because the androcentric model of sexuality was thought necessary to the patriarchal institution of marriage and had been defended and justified by the leaders of the Western medical establishment throughout all of time, basically, marriage didn't always cure the disease. And this was represented by an ordinary and persistent functioning of women's sexuality outside of that dominant sexual paradigm. So this relegated the task of relieving symptoms of female arousal to medical treatment, which made doctors inherit the task of producing orgasms in women because it was the job nobody wanted. Like many husbands, doctors were reluctant to inconvenience themselves in performing what was considered another routine chore. Moreover, there are numerous mentions that the job required skill and attention, a technique few bothered to master. The normal androcentric model of sexuality defined coitus as the penetration of the vagina by the penis to male orgasm. but it has been clinically noted that this behavioral framework fails to consistently produce orgasm in more than half the female population. When marital sex was unsatisfying and masturbation discouraged, even forbidden, female sexuality asserted itself through the only socially acceptable outlet, which was symptoms of a disease, hysteria. Means writes, it is certainly not necessary to perceive the recipients of orgasmic therapy as victims. Some of them almost certainly must have known what was going on. But nonetheless, female sexuality was represented as a pathology, and female orgasm was redefined as a crisis of a disease and was produced clinically as legitimate therapy. So, why didn't doctors make the obvious realization that they were stimulating women to orgasm for symptoms that we know mirror arousal, like anxiety, irritability, erotic fantasy, vaginal lubrication? Because it would crumble masculinity at its very core and redefine female sexuality from a position that describes desired maternity, not orgasm, into characteristics of a sexual desire beyond penetration by a penis. It was believed that only penetration was sexually gratifying to women, and this Looney Tunes ideology was the loophole through which doctors were able to administer such treatments as electromechanical medical instrument therapy until the patient experiences hysterical paroxysm, or let's call it what it is, use a vibrator to orgasm. From here, Maines discusses the evolution of the technology from an electromechanical vibrator invented in 1880 by Dr. Weiss until the vibrators we know today. She includes several primary source and patent photos, which you should definitely check out. Maines ardently discusses the pros and cons of the various apparatuses and explores how the devices transitioned from medical aid to a for medical aid for a disease to home health aid and eventually a sexual aid. And she does this through early advertisements in women's books in journals and magazines, kind of like Dr. Adams' project with the pill ads. This, of course, was coupled with the changing and understanding of female reproductive health and sexuality in the medical field as well as the social sphere. I also want to note that Maines takes time to explain how the reduction to disease paradigm silenced women's sexuality and the obvious overwhelming gap in history and scholarship. Allow me to read one last passage that I think is really important. Maines writes, in the evidence I present here on the histories of sexuality and medical massage and hysteria, it is important to stress that the voices of women are seldom heard. It is a rare person of either sex who sees fit to leave a record even of his or her most orthodox, procreative marital sexuality, let alone of experiences with masturbation. In most historical times and places in Western culture, a woman's keeping such record would have been unspeakably shocking and unchaste. Its discovery might have subjected her to severe social sanctions. Even historians of male heterosexuality struggle with the lack of primary material. Remains may have been fragmentary or revised by embarrassed heirs or publishers. Historians must rely on largely prescriptive, androcentric, and pronatal medical sources for much of our information on humanity's most intimate activities because we have nothing else. Nearly all my sources related to members of the middle to upper classes of white women in Europe and the United States, and it would be presumptuous to generalize from them to other cultures, classes, or races. And this is why I think that this scholarship is really important to share. Because Maines has done the important groundwork and has left a call to action for other scholars of different cultures, classes, and races to join the conversation and reclaim representation within the field of health and medicine. Thank you for listening to my presentation. And don't forget to check out my handout for supplemental material to make sense of all of this. Thanks, everybody. Have a great day. Bye.